Right now, as you're listening to this, you're performing this absolute miracle of biomechanics.
Oh, yeah, completely.
It's incredibly complex, highly synchronized, and absolutely vital to your survival. And you're probably not even thinking about it. You're breathing.
Right, right.
It's this invisible, automatic engine of life, basically. Oxygen comes in, carbon dioxide goes out,
Mm.
perfectly rhythmic, effortlessly balanced, until suddenly it just isn't.
Yeah, we absolutely take the mechanics of breathing for granted, mostly because, like you said, it's a background process.
Totally.
But the moment that invisible engine starts to sputter, or the moment a microscopic airway reacts to something it really shouldn't, that quiet background process instantly becomes the most urgent, terrifying focal point of your entire existence.
And that fragility is exactly what we are exploring today. We're taking a deep dive into an incredibly detailed set of nursing lecture notes from a clinical course called NUR 102. It covers this massive topic of gas
It's
exchange.
a heavy topic, yeah.
It really is. And our mission today is to unpack the mechanics of oxygenation disorders. We're looking at conditions you've likely heard of, like COPD and asthma, and some of the most daunting threats to the tiniest among us, like RSV and SIDs.
Yeah, and plus we're going to examine the intensive, highly mechanical interventions that medical professionals use to keep us breathing well, when our own biology just fails us.
Right. It is a rare look behind the curtain of respiratory care. Like these clinical notes, they don't just list a table of contents of diseases, they detail the cellular breakdown of our lungs and exactly how nurses and medical teams physically manage those breakdowns on the front lines.
Exactly. It's the gritty reality of it.
Okay, let's unpack this because the sources start by looking at a long-term gradual breakdown of the lungs. Let's talk about COPD, or chronic obstructive pulmonary disease.
So COPD is basically an umbrella term. It covers pulmonary diseases that cause chronic obstruction to airflow.
Yeah.
The central physiological problem to understand here is air trapping. The lungs, they fundamentally lose their ability to efficiently exhale, which just traps stale, depleted air into the body.
Which sounds awful.
It is. And the clinical notes highlight two primary profiles of COPD. You've got emphysema and chronic bronchitis.
And the descriptions in the notes are just incredibly vivid. They actually refer to patients with emphysema as pink puffers and those with chronic bronchitis as blue bloaters.
Yeah, the terminology really sticks with you.
It does, and I want to break down why that is, because the underlying mechanics are like totally different. If we think about emphysema, it helps to imagine a balloon.
Oh, that's a good way to look at it.
Right. Like a healthy lung is like a brand new balloon. It has great elasticity. You blow it up, and when you let go, it immediately snaps back, forcing the air out.
Exactly.
But emphysema is like a balloon that has been blown up and stretched out 10,000 times. It's completely exhausted. It's lost its snap.
Yeah, and that loss of snap is what we clinically call a loss of elasticity. And it mirrors the exact cellular breakdown happening inside the chest.
Right.
In emphysema, there's a literal destruction of the alveoli. Those are the microscopic air sacs, where the actual exchange of oxygen and carbon dioxide happen.
Wow, so they just get destroyed.
They do. And because that tissue loses its elastic recoil, the lungs become permanently hyperinflated. Air goes in, but without that snap, the lungs just can't push it back out.
Which makes sense. The notes mention this leads to an anteroposterior diameter increase. Are we just saying their chest physically changes shape because their lungs are stuck permanently inflated?
Precisely. We call it a barrel chest.
A barrel chest, got it.
Yeah, the rib cage physically adapts to the constant hyperinflation. And because they can't exhale fully, carbon dioxide gets permanently trapped in the bloodstream.
Oh, man.
Yeah, this alters the body's pH, actually turning the blood acidic. It's a highly dangerous state called respiratory acidosis. Their bodies are literally running on a toxic pH.
That is wild. And they're called pink puffers because they are constantly puffing, right? Working insanely hard to force that trapped air out through pursed lips, which keeps their complexion somewhat pink, but leaves them perpetually exhausted.
Exactly right.
Now, contrast that with the blue bloaters. Chronic bronchitis. If emphysema is a stretched out balloon, chronic bronchitis is, well, it's like an intricate plumbing system that is entirely clogged with thick, tenacious sludge.
Yeah, sludge is the perfect word for it. That sludge is driven by chronic, relentless inflammation of the bronchine and bronchioles, usually from constant exposure to irritants.
Like smoking and stuff.
Mostly, yeah. The airway's defense mechanism is to produce mucus to trap the irritants.
Mm.
But in chronic bronchitis, it overproduces a massive amount of incredibly thick mucus.
Just constantly making it.
Yeah, and the clinical definition in the source, it actually requires a patient to have a productive cough lasting more than 3 months for 2 consecutive years.
3 months for 2 years in a row. That is just a brutal reality to live with.
It really is.
Yeah.
They struggle to pull oxygen through that constant mucus plug, which leads to chronic hypoxia, low oxygen, and eventually cyanosis, which is a bluish tint to the skin, hence the blue bloater.
Right, the blue tint.
But the ripple effects are even worse. The notes highlight that this condition frequently leads to right-sided heart failure.
Wait, okay, hold on. How does lung sludge break the heart? What's the mechanical connection there?
Okay, so think of the heart and lungs as a closed loop. The right side of your heart has basically one job: pump blood into the lungs to get oxygen.
Okay, tracking.
But if the lungs are heavily scarred, inflamed, and clogged with mucus, the blood vessels inside them squeeze tight. The pressure skyrockets. Suddenly, the right side of the heart is pumping against an enormous physical wall of resistance.
Oh, wow. Like pushing against a closed door?
Exactly. Over time, the right ventricle works so hard that the muscle thickens, exhausts itself, and simply fails. Fluid then backs up into the rest of the body.
The physical toll this takes on a person is just staggering. I mean, the notes mention patients having to adopt a tripod position standing or sitting while leaning heavily forward, supporting their hands on their knees.
Yeah, you see it a lot in clinical settings.
They are basically trying to create mechanical leverage with their collarbones just to take a breath. And the detail that really stopped me in my tracks: simply eating can exhaust them to the point of severe weight loss.
Yeah, it's devastating.
Why does chewing a sandwich exhaust someone so much? I mean, it's just a sandwich.
Because digestion requires massive blood flow and oxygen. But more importantly, think about the mechanics of swallowing. Every time you swallow, your airway briefly closes so food doesn't go into your lungs.
Right, you hold your breath for a second.
Exactly. For someone with severe COPD who is already in a profound oxygen deficit, sacrificing even a single second of breathing to swallow food is physically unbearable. They literally have to choose between breathing and getting calories.
Wow. Which brings us to how we get here in the first place. The source is very clear on the risk factors. Tobacco smoke exposure accounts for up to 90% of COPD risk.
Huge factor.
But there is this hidden variable in the notes. Less than 1% of cases are caused by a genetic condition called alpha-1 antitrypsin deficiency, or AAA. We'll definitely come back to that genetic piece later because it really feels like a glimpse into the future of medicine.
What's fascinating here is the sheer breadth of the nursing interventions required just to manage this. It isn't just, handing out pills. Nurses are actively retraining the body's mechanics.
Great, the mechanical fix.
Yeah. They teach pursed-lip breathing to artificially recreate back pressure in the airways to keep them open. They position the patient in high Fowlers, which means sitting them strictly upright to let gravity drop the diaphragm and maximize lung expansion.
Makes total sense.
They even have to monitor the patient's face for skin breakdown just from the constant sheer friction of wearing oxygen masks all day.
So COPD is this slow, agonizing, progressive decline. But we've also seen how airways can react in the exact opposite way. Like they can be violently and suddenly reactive, which brings us to asthma.
Yeah, asthma is still a chronic obstructive disorder, but the mechanism is entirely different. We are dealing with hyperresponsiveness.
Hyperresponsiveness, right?
Instead of a structural breakdown over decades,
Yeah.
the airways suddenly constrict. The tissue swells with edema, and the body floods the area with mucus plugs. And it's triggered by specific external factors: allergens, respiratory infections, exercise, or even severe emotional stress.
Here's where it gets really interesting, though. When you look at the source material, there is a dizzying list of medications for asthma. I mean, it's a massive chart of inhalers, steroids, and modifiers.
Oh, the pharmacology is huge.
Right. So I have to push back here. If the airway is closing, don't you just force it open? Why does one disease need so many radically different types of drugs?
You would think a single rescue inhaler is enough, sure. But that ignores the complexity of the immune system. The notes break these medications down into a very deliberate strategy: maintenance versus rescue.
Okay. Maintenance versus rescue.
Yeah, you are basically fighting two completely different battles. You have the simmering baseline inflammation, and you have the acute sudden attack.
Okay, let's use a metaphor. If my respiratory system is a medieval castle, how do these drugs actually work?
I like that. Okay, so if your airway is a castle under siege, your maintenance medications are the diplomats.
The diplomats, got it.
Their job is to constantly negotiate peace, so the invading army never attacks in the first place. These are your inhaled corticosteroids, like fluticasone, which directly soothe and reduce baseline tissue inflammation.
Keeping things calm.
Right. Then you have anticholinergics, like tiotropium. These actively block the specific nerve signals that tell your body to produce mucus. And you have leukotriene modifiers, like Singulair, which literally block the chemical messengers that sound the allergic alarm system. You take these diplomats every single day to keep the peace.
Okay, that makes sense. But if negotiations fail and the gates are breached, I'm assuming Singulair isn't going to save me.
Not a chance. Singulair works on a cellular level over hours or days. When the airway is actively slamming shut, you don't have hours. You need your rescue medications.
The soldiers.
Exactly. The soldiers physically pushing the heavy wooden gates back open. We're talking about short-acting beta-2 agonists, like albuterol. They work within minutes to chemically force the smooth muscle around the bronchi to relax and dilate, letting air through.
To ground this, the notes provide a case study of Riley, a 4-year-old girl recently diagnosed with asthma. You look at her home environment, and it is a minefield of triggers.
A complete minefield.
The family has 2 dogs, 1 cat. The house is completely carpeted, which, traps dust mites. And her mother smokes 2 packs a day inside the house.
It is the perfect storm for a hyper-responsive airway. The nursing care plan here relies heavily on parental education. The medical team has to convince the family to fundamentally re-engineer that home environment.
Which is probably really hard to do.
Very hard. But just as importantly, they have to teach the parents how to recognize an attack. Because in children, asthma doesn't always look like textbook wheezing.
Yes. This was one of the most surprising details in the entire document. You expect chest clutching and gasping. But the source notes that an asthma exacerbation in a child might present as restlessness, or they might complain that their chin, neck, or chest is itching.
Yeah, the itching is a bizarre one if you don't know the anatomy.
Right. Why in the world does a child's neck itch when their lungs are closing?
It comes down to nerve wiring. It's a phenomenon called referred pain. The vagus nerve supplies both the lungs and the lower face and neck.
Oh, interesting.
Yeah, so when the lungs go into sudden severe distress, they fire intense warning signals up that nerve. The child's brain gets overwhelmed and frequently misinterprets that distress signal as an itch or a strange sensation on the chin or neck.
That is wild. Just completely misinterpreting the signal. The notes also mention they might complain of stomach pain.
Yeah, and that's entirely mechanical. When a child can't pull air in using just their diaphragm, they start desperately using accessory muscles, including their abdominal muscles, to literally drag the air into their chest.
Oh, wow.
So their stomach hurts because they are doing an extreme, localized abdominal workout just to survive.
And if a parent misses those bizarre signs, the stakes are terrifying. The notes issue a severe safety alert regarding a complication called status asthmaticus.
Status asthmaticus is an absolute medical emergency. It is a severe, relentless bronchospasm that completely ignores those rescue soldiers we talked about.
The albuterol just doesn't work.
Right. If the airway doesn't respond to usual treatments within 30 minutes, the patient goes into extreme distress. Their neck veins distend from the internal pressure.
Oh, geez.
If the medical team doesn't immediately intervene with emergency intubation, systemic steroids, and epinephrine to chemically break the cycle, it leads to respiratory arrest.
So Riley's case shows us how sensitive a child's airway is to triggers in the air. But even if a room is perfectly clean, with no dander or smoke, there are microscopic threats that don't trigger allergies but actively attack the airway itself. Which brings us to RSV.
Respiratory syncytial virus. For most healthy adults, RSV is nothing.
Like a cold.
Exactly. You might get a mild sniffle, recover in a few days, and never know you had it.
Yeah.
But for infants and children under 1 year of age in the U.S., it is the #1 cause of bronchiolitis, severe inflammation of the small airways, in pneumonia.
And the transmission data in the notes blew my mind. RSV survives for up to 6 hours on hard surfaces like cribs and countertops.
6 hours is a long time for a virus.
Right. Think about that as an invisible, slow-drying paint. An adult with a mild sniffle touches a countertop. 4 hours later, a parent touches that same countertop, then wipes their baby's nose. The virus transfers perfectly.
Yeah, it's highly contagious.
But why is it so devastating to a baby when it just gives an adult the sniffles?
It is pure physics and anatomy. Think of an adult's airway like a garden hose and an infant's airway like a tiny plastic coffee stirrer.
Okay, garden hose versus a coffee stirrer.
Yeah, so if an adult's airway lining swells by 1 millimeter due to RSV inflammation, It barely impacts the airflow through that wide hose.
Right, plenty of room left.
But if an infant's airway swells by that exact same 1 millimeter, it essentially blocks 50% of the coffee stir.
Yeah.
Any inflammation at that size is catastrophic.
That makes so much sense, just the scale of it. And it explains why the treatment protocols detailed in the nursing notes are so rigorous. It requires strict contact isolation. Infants are frequently placed in oxygen hoods.
Yeah, those are intense to see.
Right, which are these literal clear plastic boxes fitted over the baby's head to deliver a constant flow of highly humidified oxygen. And nurses have to meticulously track hydration, ensuring the infant is producing an output of at least 2 milliliters per kilogram per hour. It is a state of constant vigilance.
And that level of vigilance is echoed in an even more daunting pediatric respiratory topic in the source sudden infant death syndrome, or SIDs.
Yeah, that's a tough word.
This is the sudden, unexpected, and unexplained death of an apparently healthy infant, mostly occurring between 2 and 4 months of age.
It is every parent's worst nightmare. And the scariest word in that definition is unexplained. Death occurs during sleep with no audible cry. But what is actually happening biologically?
Well, the clinical notes touch on the fact that the actual cause is still under investigation, though heavily suspected to be genetic.
Genetic, really.
Yes. The leading biological theory right now involves an abnormality in the brainstem. In a normal system, if a baby happens to rebreathe their own exhaled air and carbon dioxide builds up in their blood, their brainstem sounds an alarm. The baby wakes up, gasps, or rolls over.
Normal reflexes.
Right. The theory is that SID's infants have a delayed or missing chemical arousal reflex. The carbon dioxide builds up, but the brain never sounds the alarm to wake them up.
So the internal monitor just fails.
Exactly.
Yeah.
Which is why, if we connect this to the bigger picture, the medical community's response is so fascinating. You look at the Safe to Sleep campaign mentioned in the notes. We can't fix the brainstem yet. We don't have a definitive test.
So what do we do?
So because we can't control the internal biology, medical management focuses entirely on hyper-engineering the external environment.
Right. Educating parents to ensure the infant sleeps on their back with absolutely no loose bedding and appropriate clothing so they don't overheat. If we can't fix the alarm system, we ensure the alarm never has a reason to go off in the first place.
Precisely. But sometimes, whether we are talking about the collapsed airway of an asthma patient or an unpredictable genetic failure, there comes a point where the body's natural machinery simply gives out.
Yeah.
The environment can't be engineered enough. Biology fails. And medical professionals must physically, mechanically intervene.
Yes, the final section of these notes dives into the reality of mechanical rescues. We are talking about highly invasive procedures, chest tubes, tracheostomies, and suctioning.
These are the heavy-duty tools used when the airway is either completely obstructed or the lungs cannot physically expand inside the chest cavity.
Let's focus on chest tubes because the diagrams in the source are intense. You have a thick plastic tube inserted directly through the ribs, through the chest wall, and into the pleural cavity. Why do we do this?
It's used to treat conditions like a pneumothorax, where air has leaked into the chest cavity, or a hemothorax, where blood has filled the cavity. To understand why this is necessary, you have to realize that lungs don't have muscles to pull themselves open. They exist in a vacuum inside your chest. When your diaphragm drops, it increases the vacuum, and the lungs are pulled open.
Okay, I didn't realize that.
Yeah, but if air or blood gets into that cavity, the vacuum seal is broken. The lung instantly collapses. The chest tube is inserted to suck that fluid or air out and restore the vacuum.
And the device it connects to is wild. It's a water-sealed drainage system. I saw the diagram. It looks like a complicated plastic briefcase. But how does water pull air out of a chest?
It relies on incredibly simple physics. Think about blowing bubbles into a glass of water through a straw. When you blow out, the air easily bubbles up and escapes the glass.
Right.
But if you try to suck air back in through that same straw, you don't get air, you just pull water up the straw. The water acts as a perfect one-way physical valve. Air and fluid can exit the patient's chest when they exhale, but the water seal prevents the room's air from rushing back into the chest cavity when they inhale.
That is brilliantly simple. And the nurses aren't just hooking this up and walking away. They are deeply analyzing what comes out of that tube. They're assessing the drainage. Is it blood-tinged? Is it cloudy or purulent, which would mean a severe infection?
Oh yeah, they monitor it constantly.
The notes even mention watching for food particles, which would indicate the esophagus has ruptured inside the chest.
It requires intense analytical skill, but it also requires an incredible ability to manage crisis.
Which brings me to the most alarming question posed in these clinical notes. It asks students, what are the nursing responsibilities if the chest tube is removed by the client?
Oh, yeah, that's a scary one.
I read that and couldn't believe it. You have a tube literally keeping your lung inflated, restoring your internal vacuum, and the patient just yanks it out.
It is a shocking concept, but it highlights the jarring difference between textbook medicine and clinical reality. In a textbook, a patient is perfectly still, rational, and compliant. In reality, you have a patient waking up from major trauma, or they are in a state of severe hypoxia. When the brain doesn't have oxygen, it doesn't think rationally, it panics. It operates on primal fear.
Wow.
The patient feels a strange tube in their chest, they panic and they pull it out.
But the vacuum seal, room air would just rush directly into the hole in their chest, right? The lung would instantly collapse again. What does a nurse even do in those 10 seconds?
It is an absolute chaotic emergency. This is why the notes emphasize what nurses must keep at the bedside at all times. They have to have specific sterile supplies ready, primarily an occlusive dressing. The nurse has to immediately slap that airtight dressing over the open wound and tape it down on 3 sides
Wait, why only 3 sides?
to create an impromptu biological one-way valve. When the patient exhales, the trapped air can push out through the untaped bottom edge. But when they inhale, the dressing gets sucked flat against the skin, preventing room air from entering.
That is amazing.
It highlights that nursing isn't just about sterile technique. It is about anticipating chaos. It's about knowing how to instantly hack the physics of the human chest to stabilize a patient when human nature overrides medical intervention.
It's just incredible under pressure, and we see that same level of intensive intervention with tracheostomies, where a surgeon makes an artificial opening directly into the trachea to bypass the upper airway entirely,
Right.
and suctioning, where nurses physically vacuum secretions out of the lungs when a patient is too weak to cough them up.
And all of these interventions, the chest tubes, the trachs, the suctioning, they are all artificial bridges. They are temporary mechanical measures to keep that invisible engine running while the medical team desperately tries to heal the underlying disease.
So what does this all mean? We started this deep dive by talking about how easily we take our breathing for granted. And looking through these clinical notes, you really grasp the profound fragility, but also the astonishing resilience of human gas exchange.
You really do.
From the microscopic alveoli destroyed in a pink puffer with emphysema, to the sudden, terrifyingly constricted airways of a 4-year-old with asthma, to the mechanical water seals literally holding a trauma patient's lungs open. It is a complex, beautiful, and highly vulnerable system.
It truly is.
Yeah.
But as we look at how this system breaks down and the extreme lengths we go to fix it, there's a very subtle through line hidden in these clinical notes
Yeah.
that points to a radical shift in how we might treat these disorders in the future.
The genetics.
Precisely. We spent all this time discussing environmental triggers, secondhand smoke, pet dander, RSV, surviving on countertops, optimizing sleep environments.
Right.
But the source explicitly notes that less than 1% of COPD is driven by that AAT genetic deficiency. It also highlights that the missing arousal reflex in SIDs is currently thought to be genetic, with possible genetic testing in the near future explicitly mentioned in the notes.
So while we're currently hyper-focused on engineering the outside world, the internal blueprint might be the ultimate key.
Exactly. It leaves you to wonder, what happens to the future of respiratory care when we don't have to wait for symptoms? What happens when we can look at a newborn's DNA and definitively predict their lifetime risk for conditions like COPD or SIDs before they even take their first unaided breath?
That is wild to think about.
If we know the internal engine is genetically predisposed to stall, how does that fundamentally change the way we live, the way we treat, and ultimately the way we breathe?
Unlocking the genetic code of the invisible engine. That is a deeply provocative thought to leave on. Thank you for joining us on this deep dive into the source material. The next time you take a deep, effortless breath, maybe give a little mental nod to those millions of tiny alveoli doing all the heavy lifting in the background. We'll catch you next time.